And you guys don't have to deal with me anymore. Hopefully for all. Okay, so this last block, some of this stuff kind of fits together and then it kind of goes off to another world. So we have our allergies. You're going to have some of the Pharm stuff, which kind of will tie into the allergies. So when we go through this lecture, make sure that you're paying attention because we can use those same drugs when we're talking about pulmonology. We use the same drugs, but in a different way, different route, okay? So once you learn the mechanism, and you're gonna see, we've seen some of these before, you'll kind of know what we're doing when we're talking about our Pharm. Then we'll talk about contraceptives, which are very important. We'll talk about drugs and medications in pregnancy that we need to make sure that we're watching out for. So when we're going through this block, just again, mechanisms are going to be your big things, your clinical use, talking about our contraindications, adverse effects. Those are the big routes that we're going. When we talk about our contraceptive lecture, you're actually going to be choosing the contraceptive for the patient. I will give you a table for you to properly choose the correct contraceptive for that patient. And those are probably like that's probably the most confusing block that we have. When we talk about Pharm, y'all are going to get that from Colonel Cola. There's several different guidelines that are available for you to use whenever you're talking about treating asthma, COPD, things like that. I am going to teach you the way, depending on which guidelines she uses, may be different. So understand that even when you're in phase 2, you may have one preceptor who teaches you one way and then another one who teaches you a different way, because I always tell y'all there's more than one way to skin a cat, okay? So just pay attention to what I'm telling you here for this class, and then when you're doing any other class, pay attention to what they're telling you in there, okay? I'm going to try to focus on this. We have 50 slides for this. We're going to finish this today, and then we're going to stop. I'm not going to try to go any further. We already wasted 24 minutes. Are you ready? If this closes, then we're just not having class today.
Yes.
Don't wish for it to. All right, so allergic rhinitis. So y'all talked about this in heat a little bit last semester, right, with rhinitis. Okay, so understanding here with our drugs, essentially, we're targeting the symptoms that our patient is going to present with, and we're trying to make them, I guess, more comfortable, right? We want to prevent the symptoms that they will be presenting with. So a lot of these patients who also can have the allergic rhinitis, you may see that they also have asthma. Sometimes this stuff kind of all comes together. Sinusitis. They may also have other type of IgE-mediated type of diseases that are coming along with this. So when you look at this, you have these symptoms that are occurring 2 or more days, usually in a row, and then more than 1 hour. So when you're looking at the circle, that's all I was wanting you to know from here. This is what we're looking at. You have intermittent and you have persistent when we're talking about allergic rhinitis, right? They're having allergies, that IgE component of it. So intermittent meaning only sometimes. It happens to me, it comes and it goes, right? And then you have your persistent, which is, hey, it's like all the time, year round, it's not discriminating, okay? So I have to worry about this all the time. When you're looking at our classification, there's 2 different ways. So you see your seasonal, perennial, or you have it now where we base it off of the frequency that that patient is presenting with their allergies. So you have intermittent or persistent, and then you have mild and moderate to severe. So when you're looking at your intermittent, I guess the number that you can write really big in between your intermittent symptoms and your persistent symptoms would be 4. That's like how you know, hey, things are, am I going intermittent or am I going persistent? So if I'm less than 4 days, I'm intermittent. If I'm more than 4 days, I'm persistent, okay? And then when you're looking at your mild is there's really nothing that's being interrupted, right? I can get my normal sleep, I can go to work, I can do everything, I can study perfectly fine. But if I'm talking about my moderate to severe, any of those normal daily activities are interrupted, right? So I can't sleep. Maybe it's waking me up out of my sleep because like I can't breathe because I have so much inflammation. Or I have to keep stepping out at work, or I'm just so uncomfortable because I didn't sleep that now I can't function at work, okay? So you're intermittent, less than 4 days, persistent, over 4 days, mild, nothing is disrupted, versus your moderate to severe, something is disrupted, right? Whether it's their sleep, their work, what have you. This is just telling you the goals, right? Help stop those symptoms that the patient is having. The biggest thing that we can do is try to avoid whatever that allergen is, okay? So if there's an allergen that is causing the issue, avoid the allergen, right? Sometimes we can't do that. So we have our meds, so your pharmacotherapy, and then we have immunotherapy, where you can take them to, or they can get referred to the allergist, and then they can get allergy shots. It is a lot of work for allergy shots. They are based off of that patient and what that patient is allergic to, but they have to go in for a pretty long time before those allergy shots actually start to work. So don't think that that's like a answer to everything. They are good, but we try with our other pharmacotherapy first before we send them to that allergist. Quick check on learning. So this person wants assistance help with her allergies. Her symptoms are 5 days per week for the last 6 weeks, and she keeps saying that her sneezing and runny nose is interfering with work. What are we classifying her as? Persistent moderate, right? Persistent because we're over 4, right? Remember I told you to draw that 4 in between? So we're over 4, and it's interrupting something. As soon as you hear that something is interrupted, you know that we're moderate to persistent, okay? So that was B. All right, these are tables. You're going to have to remember said tables. What you're remembering from the tables are what I have in the box. I'm going to simplify these boxes for you to try to help you remember what goes into the box. So, this is what we were just talking about, right? We said we had intermittent, mild, and we can have intermittent, moderate to severe. And then you can have persistent, mild, and persistent, moderate to severe, right? Because those were the only ways that we can classify our patients. When you're looking at your intermittent mild, all right, what you see here is I have OAH, which stands for your oral antihistamines, and we're going to get more into the drugs as we go along. But my oral antihistamines, preferably my second generation, because they have less side effects than my first generation. Remember, as our generations continue to go up, we are trying to get rid of side effects, or we're trying to target more things. So when we're talking about our antihistamines, what we're doing with that second generation is trying to say, hey, I need less side effects. So what you see here is, let me see if I can zoom in without messing things up. What you see here is that we have our oral antihistamine, or you can have an inhaled antihistamine. 1 or 2 options, oral or inhaled, as long as they have an antihistamine. If I ever tell you that your patient has injections, then you're always going to say, hey, do you need some pseudoephedrine? Because that helps with the nasal ingestion that they have, okay? So that's all this is saying. So what you want to do for your mild intermittent patient is give them an antihistamine, whether it is intranasal or oral, doesn't matter. And then if you see congestion, pseudoephedrine. Those are the options that we have. Here, we're looking at our intermittent, moderate to severe, right? So intermittent, moderate to severe. Now, my patient is more, they're more affected, right? Their symptoms are more prevalent. They're having more issues. So when we look at this, again, I can have my oral or inhaled antihistamine. Now you see that we've introduced steroids, right? So your INCS, this is your intranasal corticosteroid that you can give to your patient, right? Because it's more serious now, right? Moderate to severe, now I've introduced steroids. And then when you look at this, this is where we have a lot of questions. So this inhaled antihistamine and corticosteroid is a combo product, right? So the benefit of that is that you can have your person just take one, like they're only using one intranasal spray. Whereas when you see INH plus INCS, that's 2 separate sprays that they have to do. Okay, so it's less convenient for the patient. We usually see this happen if we add on treatment. So let's say I started my patient with an inhaled antihistamine, and then I was like, okay, well, let me see if I need to progress, and I add an inhaled corticosteroid. That's where I can see them using those 2 together. And if I see a response, then I can just give them a combo product. So all this is saying is the same thing that we did before. I need to give them an antihistamine, oral or inhaled. If that doesn't work, and these are in order, if that doesn't work, then I can have my inhaled corticosteroid. alone. And if that doesn't work, then you can see where I can do the combo with adding the inhaled corticosteroid with the inhaled antihistamine as two individual products or as a combo product, doesn't matter. And do the same thing like we said before. If I tell you that they have congestion, add the Sudafed, okay? So pseudoephedrine would be added to that. This is now your persistent mild. So with my persistent mild, this is like year-round, they're having these symptoms. So now I need to be a little bit more aggressive. So we said before that we had our steroid as the second line kind of thing, right? When we were at our intermittent moderate to severe. Now it has moved up to first line. So now I have my inhaled corticosteroid. Second line, I have my oral or my inhaled antihistamine. So now I'm looking at an antihistamine. And then if there's congestion, Sudafed. Okay? So when we're talking about persistent, we like to use our steroids more because they're having those symptoms more frequently than when we were talking about our intermittent where we liked our oral first. So essentially you just kind of flopped what we did on the intermittent side now that we're persistent. And then looking at your persistent moderate to severe. So now I have my inhaled combo, right? Because not only are we persistent, we're more moderate to severe. So now I have my combo of inhaled antihistamine with my inhaled corticosteroid, whether it's alone or as a combo product. Second line, I have that inhaled corticosteroid alone. And then you see third line, I have my inhaled antihistamine. Okay? Anytime with any medication, even if I'm not doing an oral second gen, which is how they have this listed here to do the pseudoephedrine, you can always add on pseudoephedrine anytime somebody presents to you and they're telling you that they have congestion. So no matter which med they're on, always think about your pseudoephedrine. You can give them that tablet by itself. The reason why we have that oral the second gen with pseudoephedrine on these charts is because we can give those in a combo product, so that way your person is just taking one med. But then you lose that effectiveness of going directly to the site where I'm having my issue. So you can orally give them that pseudoephedrine and then give them their nasal spray, depending on how we classify them. Okay? So remember the names that are going along with what is in the box. I'm not going to go all the way down and that deep into this chart and going over here in these further right things. That's usually when you're going to start referring those patients. If you've tried these things and then they're not working, you're going to end up referring those patients. Okay. All right. So now we're going to look at the drugs that we're actually going to use, which are the things that we were talking about previously in this chart. So when you're talking about antihistamines, essentially what that's trying to do is reverse the histamine release, trying to stop that inflammation that we may have, stop the runny noses that we may have, depends on how that patient presents with their symptoms. So you see H1 antagonist against those histamine receptors. So if I get there first, now that histamine can't bind, and therefore I stop that cascade of having all of those issues occur with the inflammation. And so that's why you see the mast cells, all those granular cells, that's stopping all of that from happening, okay? You have your first gen and you have your second gen. When we're looking at our first gen, just think of them, they're kind of out there, they're wild, non-selective. We're going to see a lot more side effects, a lot more anticholinergic effects. You'll see a lot of drowsiness when we're talking about these medications. And then when you're looking at your second gen, they're more selective, less side effects. You'll see people not complaining so much about the drowsiness that we see with our first gen. So a lot of the meds, as we go through them, they're like, oh, I've seen those. Most of those are going to be your second gen meds. When we talk about the first gen, most of the time we're using those because we want to put somebody to sleep. Looking at our clinical use, again, just trying to help us with some of those symptoms that patients are experiencing, not just with allergic rhinitis, but you can use this when people are having colds, right? Because those symptoms look very similar, hay fever, different things like that, or just they have allergies and they're presenting that way. Your dosing. When we look at our first gen compared to our second gen, our first generation drugs are going to be ones that require more frequent dosing, right? They're older, they need more care. We gotta pay more attention to them. So what do we think is gonna happen to my adherence if I have to take it several times a day? It's gonna go down, right? My second gen, usually I can take it once, maybe twice a day. But most of the time with our second gens, we're taking those once a day. And then looking at your intranasal, especially if somebody has that congestion, again, because it is going to the site where my issue is, you can see that they have a greater response when we're talking about that, the improvement in congestion. Now, it doesn't mean that you don't have to offer that decongestant. You can still offer your pseudoephedrine in those patients because sometimes it may not work. So if I can tackle that congestion, which is usually what is more disruptive to your patients, if you can tackle that and relieve some of that, then that's where you'll get a greater response. Looking at our first generation, I've hit on this a couple of times already. Our adverse effects are going to vary depending on which ones we're looking at. So our first gen, we said that we can have those anticholinergic effects, right, where I'm drying stuff up. And my biggest thing that my patients are going to complain about is drowsiness. So that's why you'll see some of these first gen meds, we're using these when we're talking about some of those antihistamine, some of the effects of trying to put someone to sleep. We use it for the side effect profile. Hypotension, because of that alpha blockade that we have occurring in there, so just remember these things. And then with our children, we can see where sometimes instead of that drowsiness, you'll see a paradoxical excitation occur in them. And that's why I told y'all, like sometimes if I give my kid Benadryl, like that's what that means, right? It's not making them drowsy, it's riling them up. Your second gen, very well tolerated. Most of the time, the only things that you'll see is some of your patients may complain of a headache, not very common. And then those intranasal formulations, and you're going to see this as we continue to go through this lecture. Anything, remember that I tell y'all, like even when people do eye drops, sometimes they will tell you that they can taste it, right? Because we're all connected. Same thing with the nose. Whenever some people are doing the intranasal formulations, depending on which medication you give them, they'll have a bitter taste. Some of them have like a floral taste to them. Some of them are just not great at all. So it just depends on how we formulated that medication. And then looking at your interactions, if you're looking at somebody who has anything else that is a CNS depressant, or if they have any other anticholinergic, right, we have those additive effects that could occur. So somebody drinks a lot of alcohol or on any other med that could help or increase their drowsiness, you're increasing the risk of that, especially if you're using one of your first gen medications. Here's a list of all of our first generation medications that we have. So they're all listed on this side. So this is their generic names that you have. The one that most people know is going to be your diphenhydramine or your Benadryl. These are all of your brand names that you have, and then your effects that you would typically see. So these are the big side effects that we talked about when we were talking about our first gen, right? So I have my sedation, right, or my drowsiness, and then I have my anticholinergic effects. So when I'm looking at my alkylamines, what I see is that I don't have a lot of drowsiness, but I do have some of those anticholinergic effects, with your clofenamine being the one that we can most likely see used in pregnancy. When you're looking at your diphenhydramine, the side effect profile of this is just not fantastic. Also remember, if they don't have enough time to sleep, that they have that rebound effect, but we do use this a lot, and anything that you see that says PM likely has diphenhydramine in it. Also a good option for our pregnant women, just make sure that they're not standing up, that they don't have anywhere to go, because if they do, we can potentially have them fall, which could be harmful. You also see that it's safe in our children, as long as they're over 9 kilograms. Again, when you're talking about drugs in any of your medications, if you have an option to look at a weight base, that is better than looking at age. You have some kids who are larger than they should be, and you have some kids who are smaller than they should be. So if you have something where you can weigh them, that's more specific for you, that's more patient specific, and you're not giving that generalization, because yes, I could have a 6-year-old, but if my 6-year-old is super tiny, I could overdose my kid if I was just basing it off of the age instead of off of the weight. So anytime you see a weight-based option, always better for you to look at that. Promethazine, we've heard about promethazine. Most of the time when we're using this though, it's for nausea and vomiting. Again, you see both of those side effects, it's red. Your hydroxyzine and your meclizine, these are called piperazines, okay? When we look at this, most of the time, we're not, again, using this for allergies. Your hydroxyzine, you can use this for anxiety, you can use this for itching, hives, things like that. Whereas whenever you're looking at your meclizine, most of the time you're going to use this for like that vertigo. So when people are like very dizzy, we can use these. The sedation is not as marked as you'll see with your Benadryl, but you will see some people who are sensitive to it, especially as you increase their dose, you're more likely to see that. Anticholinergic effects are minimal. Cyproheptadine, when did we talk about cyproheptadine? Serotonin syndrome, right? So this was what we were using to reverse it. So it's really an antihistamine, right? Now, your second gen. This is like where most of our drugs are. This is where you're prescribing from more often than not. When we're looking at this, we have less sedation, we have less anticholinergic effects. So think of these as the 2.0, right? This is the better version. Your second gen have less side effects. The big thing that we said that people complained about was a headache, right? That's all we were really worried about when we were looking at these. So again, here are your medications that you have here, your fexofenadine, loratadine, desloratadine, cetirizine, levocetirizine, azethylene, and your olopatadine. These we'll talk about. These are different routes that we would be using when we're looking at this, versus these are your oral options that you have available to you. Over here, just pay attention again to what you're more likely to see in pregnancy. So your loratadine, your cetirizine, and then looking at your, when we get to these slides, we'll kind of talk more about these. But again, just look at your comments. Make sure that you understand if you had a choice between the first generation and the second generation, that you are going to want to choose the second generation because that side effect profile is a lot better and it's more tolerable to your patient. They're allowed to function. They also, these, when we look at these, you can see people take these and still be able to go about their day. When people take those first generation, a lot of times they'll be like, I have the hangover effect. Or they take it during the day and now they're sleepy while they're at work. So make sure that you're paying attention to what the person has going on. If they're elderly, do I prefer a first gen or a second gen? A second gen, right? So my first gen is making them drowsy, right, unstable, and then those anticholinergic effects are also not going to be great for them. Your leukotriene antagonists. So these medications are not as new anymore, but they're like newer to this kind of circuit. So when you're looking at this, inhibits your cysteinoleucotriene, which is an inflammatory mediator. We're going to go over that pathway on the next slide. So just understand that this is trying to antagonize the leukotriene, which is what can lead to more inflammation that we see in some of these allergies and allergic rhinitis that your patients can have. Your clinical use, just understanding that it is something that is available for us to use to help with the allergy symptoms that someone has. They're very effective medications, very well tolerated. The big things that you'll see from here is going to be those headaches again, and then that mood or behavior changes. Those are a big deal with that mood and behavior because, again, if you have somebody who has suicidal ideation, if they already have depression, you need to make sure that you're monitoring them whenever you put them on this med and that they are stable before you put them on this medication. The drug that we have for this class is going to be your montelukast or your Singulair. You see that we have several different dosage forms. So you have granules, you have chewables, and then you have just regular tablets. This comes into play because if you have a younger child who has allergies, you can help them by giving them Singulair or montelukast because look, I have as long as they're 6 months old, I can give them this medication, okay? So 6 months and up, they can use them. The granules, what we do is they can sprinkle them on top of like applesauce or something like that because maybe the kid can't chew yet or they don't chew very well. So you can put there's like little sprinkle tablets and you can kind of put them on top and they get the medication that way. The other thing with this, you'll see it used off-label for different things. So if someone has like snoring and they're a peds patient, you'll see them sometimes try to use the montelukast for that also. So good med, headache, mood, behavior changes. So make sure that your patient is stable if you are going to start them on this medication. All right, this is the mechanism of action. Of a lot of these drugs that we're going to talk about in this block, we're going to also talk about our corticosteroids. You're going to see the same exact thing. We saw this when we talked about some of our NSAIDs as well. So when you look at this, let's say something happened. This is our arachidonic acid pathway, right? So this is how we get inflammation. This is how we get our allergies. All of these endpoints that you see down here, asthma types of responses, this is how it all kind of goes through this pathway. And then you see all the drugs that we have to try to inhibit or stop those end results, right? So I have my phospholipase inhibitors, corticosteroids that I can use, my LOX inhibitors, NSAIDs or aspirin, colchicine, my receptor antagonist for my leukotriene receptor antagonist that I can use here. So essentially what happens, your phospholipid gets disrupted, and then you have your phospholipase which gets activated. So therefore you can get your arachidonic acid, and then there's essentially two big pathways that you're going to go through from there. You're going to go through your LOX pathway, or you're going to go through your COX pathway. Your COX is more so the pain types of things that we were talking about, and this is where our pain meds are working to block that, so that we don't have the inflammation. It also helps with pain. And then you have your LOX pathway, and this is essentially just trying to say, hey, I want to try to stop inflammation. I'm trying to stop this congestion that the person has, or those bronchospasms that someone could have. So when we're talking about allergies, we're typically in this red box. When we're talking about pain, we're typically over here, okay? So that's what you're seeing here with your mechanism of action, and you will see this again when we talk about our corticosteroids. All right, our decongestant. Also, because we started 20 minutes late, if you need to go to the bathroom, just go ahead and go so that I can make sure that I finish this today so we're not behind. Our decongestants, another name that you can hear this kind of mimicking is a sympathomimetic. We have several different drugs that we use here. So you see your oxymetalazone, your pseudoephedrine, and then your phenylephrine. This we will continue to hear more about on if they're going to take it off the market or not. So just make sure whenever you get out, if this is going to be something that's still around, it may or may not be. When we look at these drugs, essentially what they're trying to do is decrease the blood flow to that area to relieve the congestion, to help relieve red eyes, because we'll use some of these in red eye situations as well. And therefore, if I have less pressure, then I can breathe a little bit better, right? I'm helping decongest that patient versus if I were congested, right? Oh, other thing, we'll talk about this a little bit more, but with our pseudoephedrine, we kind of touched on it a little bit. This is what they're using to make meth. And so they have to go to the pharmacy to actually purchase this, show an ID, have a valid ID, and it logs it in the system to where they can't buy more than what they would potentially need to make meth. Of course, you can get several people together and you can still figure it out. So that's why, again, if you are a provider and you know that someone legitimately does need it, you can write a prescription and we can fill it in the pharmacy here if they're getting it in the MTF. If it is something that they're using quite a bit, we might look at you like, okay, well, why does this person consistently need pseudoephedrine, okay? So make sure that it makes sense as to why they're telling you they need it so that you're not helping with the meth farm, okay? Mechanism of action, kind of what I was already talking to you about before, right? So working on that alpha-1, and so when I'm talking about alpha-1 agonist, therefore I can have some vasoconstriction, and therefore I can relieve some of that congestion because now I have decreased how much is flowing through that area, which is my problem. That's why I am congested. You'll also see that you can have some of that, the relaxation of the broncho-smooth muscles. So you can have some of that kind of relaxing. You'll see that you will have some patients where this can be very activating if they're very sensitive. So what that means is I can have now that increased heart rate in those patients, and some of them will also say like, hey, I can't go to sleep at night because like I'm so, like they're pumped up from the pseudoephedrine. So just make sure if somebody does have that sensitivity that they're taking it in the morning and not at night, close to bedtime. The other thing that we try to make sure that our patients know is to not take this more than 3 to 5 days. I typically tell people 3 days because it's better safe than sorry, because once they get over that, what starts to happen is they have rebound congestion, which is the big thing with these meds. They work great. They work so good that people start to rely on them and they don't know when to stop using them. So when you see this, limit topical application to less than 10 days, preferably 3 to 5 days if you can. The 3 to 5 days, anytime I have a person who's using Afrin, I always tell them that 3 days. If you have somebody who is using it for their eyes, the oxymethylazone, that I will also tell them 3 days, because then they get rebound red eye. So then their eyes are consistently red because they're consistently trying to use the decongestant. Our mechanism of, our drug interactions. So just make sure that you're understanding with our MAOIs that they have that 2-week washout period prior to them taking this medication. Most of the time when our allergies occur, it's not something that we know depending on what type of allergies they have. If they don't know, they can't have this washout period. So again, we would just have to choose a different option for them. We have other medications that won't interact that we'll talk about. Well, I guess it's not even a medication, but they can do like nasal flushes and things like that as well. Adverse effects. So again, kind of talked about some of them already, but remember we have that alpha-1 agonistic action for our mechanism. So when I look at this, now I can have that blood pressure go up. I can have my heart rate go up. Remember how I said it's like excitable to that person. Increase blood glucose levels. I can start retaining urine, okay? So just kind of going over this, making sure that you're looking at what's happening. That rebound congestion, this is what we were talking about with our topical and our nasal formulations, okay? So the 10 days versus your 3 to 5 days. And then with your increased ocular pressure, kind of the same thing, going along the lines with your urinary retention as our mechanism for that. And then your nasal irritation, more so if you're continuously, if they are in the form of a spray. Sometimes people don't spray the right way. So if you have a nasal spray, always tell your patients to kind of point outward instead of in, because sometimes they can damage their nose, and people will get a lot of dry sinuses as well. So sometimes we'll give them a saline mist to put in their nose, or like a saline gel to kind of help lubricate. But if they just point outward, it helps them a lot more avoid that happening to them, to those nasal passages. All right, your phenylephrine, this is the one that I was telling you that may or may not be on the market by the time that you're done. They've been doing research. And essentially what this does is it is a alpha-1 agonist as well. You see that we can have increases in the blood pressure, the dilating of the pupil, all those same things that we talk about when we talk about our alpha-1 agonistic properties. The thing with this drug, Sudafed PE versus Sudafed, which is just your regular pseudoephedrine, that's why I was telling you to be very specific with your patients whenever you're talking to them about this, because this is the issue that we're having. The response rate is very low when we're talking about our Sudafed PE versus when we're talking about Sudafed in regards to congestion. It's not a great medication. You see that we can use this for shock, or when someone has hypotension, their blood pressure is very, very low and we're trying to get it back up. You can see it used in some of our eye procedures that we may be performing, and then again we do use this to compound like creams that we have for steroids. Nasal congestion, we don't really love to use it for that as much, and then the eye redness. Monitoring, because of that increase in blood pressure, again, just making sure that we're monitoring for that, as you should when people come into the office anyway. When we're looking at things like shock and we're using this for shock, again, we're just trying to make sure that we don't have extravasation occur, so that's where we have that tissue necrosis and things like that happening. And then if they're on it for a very long period of time, and because that blood pressure can go up, you'll see what we have as called a hypertensive headache, right? My blood pressure is so high that now I'm having, or I'm experiencing headaches. And then that rebound congestion, again, the longer that someone is on it, 3 to 5 days for your nasal, over 10 days when we're talking about those topicals, you're likely to see that. Interactions, anything, any other alpha blocker that could be there, right? Because I'm an alpha agonist, so now you're blocking what I'm doing, and then you're atropine, because then you would get additive side effects similar to what you're having with your phenylephrine. Oxymetazoline, or your Afrin, you can also see this in some of your Visine. Again, alpha 1, alpha 2, so acting now on both alpha receptors that we talked a lot about. You see that they come in different formulations that are available, but essentially what's happening is I'm trying to decrease the blood flow, so therefore I can decrease the congestion, I can decrease the amount of pressure that that person may be experiencing in their eye, which, well, sorry, I didn't mean to say pressure. Decrease the blood flow in that area, which would decrease the redness that they're experiencing or the congestion that they're experiencing. So my clinical use falls right into that, helping with eye redness, so just the appearance of it, and then congestion. My drugs that I have available are here, again, because they are those eye drops that we're using. We still want to limit them to the 3 to 5 days. Again, I err on the side of 3 days just because I don't want to push it for 5 days. And then that adverse effect, again, anytime somebody has a eye drop, anytime someone is putting something in their nose, tell them almost the same things, just like if somebody was injecting themselves. If they have an eye drop, most of the time they're going to tell you that it burns or it stings a little bit, especially if by the time they got to using this medication, they've been rubbing their eyes, right? Now their eye is even more irritated, or if they have somehow scratched it, so they're going to see more of that stinging and burning, and then the rebound congestion if they use it for too long. This is our pseudoephedrine or our Sudafed. There's no PE behind this, right? That was our phenylephrine, so this is our pseudoephedrine. With this, direct alpha and beta, you see that this is also going to indirectly displace that norepi from the storage sites. And then what we see here, we get great nasal, it's a great nasal decongestant. Adverse effects, again, just make sure that you're understanding that this is a precursor for your methamphetamine, and therefore when we think about it, you can think of it as that you could potentially get a false positive in a patient who is taking this, especially if they're taking it for a long period of time for your amphetamine. These are your limits, so pay attention to what's in bold that we have. So because of our Combat Methamphetamine Epidemic Act, they have the thing where now they're having to use their state issued ID, we scan it at the pharmacy, and they're only allowed to have that 3.6 grams in 30 days, or sorry, 3.6 grams a day, and then a 30-day limit of 9 grams, okay? So there's a max both ways. You can't just come in and say like, okay, I bought 9 grams today, they're gonna have to come several days. And we have patients who used to do that. They come over 2 or 3 days to buy their Sudafed, and then they would wait until the next month, and it was just like clockwork, okay? So if you prescribe it, again, try to make sure that you're keeping track of it, that you're not prescribing too much of it to where somebody could be having like a neck flap. Some notes on here, and this is just marketing that some of our drug companies will do. You'll see where they'll say like, hey, I have blah, 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 HBP, or like things for people who have high blood pressure. Just understand that those are underlying diseases that you need to watch out for. Thyroid disease, especially if somebody has hyperthyroidism, right? I'm already tachycardic. I'm already kind of like excited. So if you give me something like this, you may or may not disturb or add on to my symptoms that I'm having. Same thing with the glaucoma, right? Like I'm trying to decrease the amount of pressure that I have because I already have this condition. So make sure that you're giving me a medication that isn't adding to that pressure that's occurring. And then if somebody has BPH, right, they already can't use the restroom, make sure that you're not giving additive effects to where, hey, like now they also can't urinate because they have anticholinergic, a drug that has anticholinergic effects on. Looking at your oral phenylephrine, again, this is the one that I was telling you that may or may not work when we're talking about congestion. We use this IV, very effective medication when we're talking about shock and things like that. So just understand that when we're looking at this, the only benefit that we saw with using this was that patients who had cardiovascular issues, they were less likely to have those issues occur while they were using phenylephrine. But the effectiveness as far as congestion was trash. Okay? It was not great. So that's why this has been a dispute on do we want to use this or not. This is just a summary of our drugs that we have available, telling you which ones are oral, which ones are topical, right? Meaning you have eye drop here, same thing here, eye drop here. So, or they also do the notes for this. So with this, make sure that I want you to remember, did I say eye? I did say eye. This is your nose. This one is your nose. We'll talk about another one when we get to conjunctivitis. So these are your nose. We're in allergic rhinitis. What I want you to remember from here, the drug, remember the route, right? So remember if it's oral versus intranasal, and then looking at your comments that you have are the same things that we already talked about. So when you're looking at your phenylephrine, you see that this one is not as effective as my pseudoephedrine was. Be careful when you're using this in your pregnant patients. It is a possibility for you to use it, or for them to use it, but if they have hypertension while they're pregnant, or if they're on the border of having hypertension, we're kind of more cautious with this. If it's a, like, hey, I'm only using it for a couple of days kind of thing, you will see where sometimes we will allow that to occur. And again, if you're prescribing it for a very long period of time, you should try to figure out what the underlying issue is, because it's not something that we should be using for a long time. When you're looking at your Afrin, very, very good medication. Again, make sure that we're watching out and limiting this for that 3 to 5 days. And the same thing with your phenylephrine PE, kind of short acting, not the most fantastic med. So just know that it exists. This is looking at how we are trying to help with patient compliance. We have added some of these medications together. So now what you're seeing is your oral antihistamine with your Sudafed, okay? Your pseudoephedrine Sudafed. So that's why you see PSE versus PE, which is your phenylephrine. This is your Sudafed, okay? Your pseudoephedrine. What we're doing with this is essentially saying, hey, I put these two things together so that way my patient doesn't have to take 2 pills. Now they're just taking 1, okay? Depending on which one you do, we have a 12-hour formulation and 24-hour formulation. I typically try to start my patients on the 24-hour formulation, and if they say that that doesn't work, that's when I put them on where they can take it twice a day, because usually they're going to be more adherent to just the once a day anyway. So this is how you see your Zyrtec D, Allegra D, Claritin D. The D is because it has the pseudoephedrine in there, okay? So same drugs that we had, our same antihistamines, but now we added a D to it, meaning it has the pseudoephedrine in it. These are some alternatives that we have available. Just know that they exist. So your Coracetin HVP, this was supposed to be directed at trying to say, hey, if you can't take a decongestant because you have high blood pressure, this is the drug for you. We have different ones that are available, but you see that they're not very great decongestants, okay? They can kind of work, they kind of help with some of the symptoms that a patient may be having, but it doesn't compare to what you're getting when you're using your pseudoephedrine or any of your other decongestants. Your nasal strips, this is what we would prefer in our pregnant patients, or someone who is more natural, right? We're just trying to open up that pathway so that they can breathe a lot better. If we're looking at our kids, we're looking at elderly patients, very good option for them to use. And then that intranasal saline, again, this is a good option for those who can't take medication. Trying to use this on infants is very difficult if you're talking about a saline rinse. Most of the time when we're using with our infants, we use the spray or we have drops, which helps them with their congestion. It tries to kind of get the mucus out. You're still going to have to fight them. They turn into like baby octopus, and it's like, relax. So you probably will need help when trying to like put the medication into their nose. Be very careful with that, and make sure you counsel your parents on that, because sometimes they will put these in there, like they'll try to spray it for the nose, and it could potentially get into the infant's eye, and it doesn't feel fantastic to put the saline in there. It's not going to hurt them for a long time, but it's not fantastic. So this is our intranasal saline that we're talking about. Just understanding that it's trying to irrigate or clean out the nasal passages. With this, you can have some people who they just do this every single day so that they don't get sick. Some people just like to flush. When patients are using this, especially if they're using this one on the bottom, this sinus rinse, we do have this in the pharmacy, so you could order this for your patient if you don't want to make them go out and buy it. And then these are like little saline packets. So what they do, they pour their water into the bottle. It's usually like a line that's marked for them up here, and then they'll take one of those packets and they put it in. I typically tell patients the first time that they're going to try this to do it in the shower, because it's kind of a weird kind of way to feel it for the first time and trying to not make a mess. So I tell them like, hey, get a feel for it the first couple of times you use it, do it in the shower. People who are really good at it, they just lean over their sink and they flush their nose out. So again, just warn your patient because it can become kind of messy. Any of your patients can use it. You have your home remedy here. I'm not expecting for y'all to memorize this. Just understand that they can make this at home themselves. You don't have to order it for them. Side effects, make sure that they are using clean water. Make sure that they are emptying out the rinse from the time that they used it before and that they leave the top off of their bottle for that water to dry out. Some people will rinse out the bottle or just pour it out and then they have their boogers and stuff on the top of it. Or when they were rinsing, it kind of sucked some of that water or that mucus that they have in their nose back into the bottle and they will leave it there. And they're like, oh, I'll save this water for tomorrow. And now you have all of that stuff growing in the water that they're going to flush right back through their nose again, okay? So it sounds like common sense. People do it all the time. Make sure they use clean water. Make sure they're not using their water bottle that they had all day and then dumping the rest of it in there because now they have their mouth germs that they are now putting in their nose, okay? Clean water, all right? Intranasal steroids. So we saw these also on our charts looking at this mechanism of action. Steroids try to decrease inflammation, right? That's what they do. So now what we're doing with our intranasal steroids is we're trying to say, hey, let me decrease the amount of inflammation that I'm having in my nasal passages. The early and the late phase of a reaction, depending on when somebody came into contact with whatever that allergen was, is when you can kind of see the late versus an early phase. So just understand that these are for anti-inflammatory. They're trying to decrease the inflammation that somebody is having. Looking at this, there's 4 symptoms that people usually are going to present with whenever they have allergies. They're going to have congestion, rhinorrhea, itching, and sneezing. They may not have all of them, but those are the 4. Your steroids are good at trying to help with decreasing the effects for any of these that they have. Some of our drugs that we look at, they're only helping with the rhinorrhea, right? Some of them, they're only going to help us with itching, but when we're talking about these, they help with everything. Looking at this though, don't expect for them to work right away, 1 to 2 days, a slower onset. So most of the time, if we know that somebody is going to have contact with an allergen, that is when we're going to start them on it ahead of time, right? Especially if they have seasonal allergies, we can get ahead of it. Oh, I know that it's about to be X season. Let me start my person on their intranasal steroids that they have. Looking at this, if somebody is very congested, again, you can use a decongestant or you can use our saline that we have to try to open up their passages to where when you do give the steroid, more of the steroid is actually reaching the site that we need it to go to decrease the inflammation, all right? So sometimes, again, like I was telling you, on that chart, it shows that you can have pseudoephedrine with a second-gen oral antihistamine, but that's not the only time that we will use those. We use those sometimes just any time a patient comes with congestion. Sometimes they may not have any other symptoms but congestion, and you can just put them on a decongestant. They don't have to be on anything else. Any type of medication, even when we're talking about like eye drops, even when we're talking about, like if you're talking about a nasal spray, make sure that the patient doesn't blow their nose right after. So at least 10 minutes before they blow their nose after they're taking or using an intranasal spray. Reason being, if you put the medication up there and then you go and immediately blow it out, it's not going to work because you just decreased how much of that medication got to the site. Same thing when we talk about the eye drops. Make sure they don't squeeze their eyes after they put in the eye drop because now you're squeezing out the medication. And then this short course of a burst, we'll talk about this again when we talk about allergies, asthma. But what this burst is saying is usually what we will do is we will give them prednisone, usually for 5 to 7 days. Allergies sometimes, or asthma, sometimes we'll see it go up to 10 days. But just understand that this is an oral tablet that we would be giving them to quickly try to control the inflammation that they have. So when you hear like a burst of steroids, we usually will use these in allergies. We will use them in asthma a lot as well. If somebody has like a big exacerbation, you'll see where we'll use the steroid. And then this was our chart that we talked about before with those mechanisms and how we said, hi, where are steroids working, where are leukotriene receptor antagonists working. This is just showing you again where your steroids were working in that pathway. Adverse effects, because it is an intranasal route that we have, you can have where people are having nosebleeds, you can have where people will say that it burns and it stings, especially if they've been doing that nasal salute, right, where they have that crease or they're doing like this to wipe their nose because their nose has been running. You'll see where sometimes that causes irritation. So as I'm doing my spray, I can also have more irritation now on the inside. The more that I'm using any type of steroid, less of a risk, but you can see that growth suppression. So this is more so if we had a younger child who was using this medication that you're going to see this. That aftertaste we already talked about, again, because of that route that we have. And then the septum preparation, because they are pointing inward, that's why we tell them to go outward. And then make sure that they don't take like a huge breath in. The more they do that, the more they're going to tell you that they do taste it and they do feel the burning and the stinging. It should just be a regular inhalation that they are taking whenever they do their spray into their nose. So again, if they don't have good hand-eye coordination, just like when we're going to talk about our inhalers, it's the same thing. If they don't know how to pump and like inhale, a lot of it will get in, but more of it gets in if they can spray and inhale at the same time. Okay. Interactions, they're not too horrible. Just understand we have some minor CYP inhibitors that could affect our medications. Looking at the drug that we have available, so these are all of our different drugs. You'll see the ones that are above the red line have a higher risk of them having growth suppression, or sorry, everything that's below the red line has a higher risk of having growth suppression occur because they have more of a systemic absorption, okay? So everything below this, this red line right here, increased risk of that growth suppression. So here's your drug. Don't worry about the adult in the pediatric dose. What I want you to pay attention to is how young can I give it, right? So you have your fluticasone and your Viramis that you can give, as well as your Nasonex to your 2-year-olds, whereas almost everything else, outside of your regular fluticasone, which is 4, everything else, the kid has to be at least 6 years old. So that's what you're seeing with all of these, right? And then remember, as we got down here, I have an increased risk of that growth suppression, right? I'm more likely to see it, and I'm more likely to see it in those children who are using these. So if I did have someone who is still growing, I'm more likely going to stay above this line if I were giving them an intranasal steroid. Bless you. Over here, again, just look at your comments. That's all I need you to look at there, is making sure that you're understanding the comments that are inside. What can I use if I'm pregnant, which all of these are saying. That's all this is saying. These are generally safe if pregnant. That's all I need you to remember. And that you don't have a lot of systemic absorption. As you get down here, you have more systemic absorption that you could potentially see, which then means that you could potentially decrease that growth rate that those kids typically are having. Not so much worried about that in our adults. Your intranasal antihistamine or your steroid, we have azestolin and fluticasone. Now what you see is that we have taken those 2 medications and we have combined them together. So this is the one that you see on the chart that says IN, and then it says your AH plus your CS together. This is the combo product of that. So this was our moderate to severe cases, and it's more effective than us using either of those medications alone. It's more effective than us giving our patient those 2 medications individually, because now they're just having to use one thing instead of them using 2 things, right? The easier I make it for them, the better and more likely they are to be adherent. See that this is very good for our patients who have seasonal allergies. Again, that age of 6 is what we're typically looking at, unless we were either one of our fluticasones where you saw 2 or 4. So this falls into that same rule of what we have. And then looking at your effectiveness, again, those hallmark signs of what we see in allergies, they're pretty good because they also have that steroid component in it. The fluticasone is also in there with that antihistamine, your intranasal antihistamine. Side effects that we have, minimal when we're talking about that somnolence and drowsiness, but it's still something that can happen. Because remember, does have that second gin added on to it. And then you see your nasal effects that you have, so whether it's the nosebleeds or whether you have different ulcers that are in there. Make sure, I also tell people to clean off the top of these sprays whenever they, to get like an alcohol wipe, but not to press down really hard, because some people, they will try to clean really hard. One, a spray will come out, but also if you press hard enough, that alcohol will start to go into their spray. So if you don't think that they're going to listen very well, baby shampoo is another option, like with some water to just kind of wash it off. I just do mine with water or like a baby wipe and just clean it off. You can also see where people can have the Candida albicans infection. And this goes back to us talking about the increased risk, right, of someone having an infection because we're giving them steroids. Steroids knock off so much stuff. So a lot of the times you'll see where our patients can get these Candida infections. And when we talk about our asthma, we're gonna talk about this again. So just make sure you're paying attention to that. Changes in taste because it's going in my nose. Remember, all connected. Interactions. Same things that you would think about when you're looking at an antihistamine or a steroid. There's just not a lot. These meds they're pretty good. Anticholinergics. So when we're looking at this medication is a good medication for us to use. The one that we have is called ipratropium or Atrovent. And again, it is given nasally. Remember these names because you're going to see them again, but it's for a different indication. So it kind of gets a little bit confusing. So remember, we're still looking at allergic rhinitis versus when we're going to start talking about some of our other things like allergic conjunctivitis, or even when we start to talk about asthma, you're going to see some of these come up again. Okay, so just pay attention to the routes in which these are given, which I typically don't make you guys pay attention to, so that you can remember your clinical use. So mechanism of action, muscarinic antagonist. Again, side effect profile, not horrible, but because of that route, you're going to see that they have some of those dry mouth issues. You're going to see where they have some of the nosebleeds. So if they are having a lot of dryness, again, give them that saline. Looking over here, this was your drug. Don't worry about the dose. Just again, you see that we're safe depending on what they're presenting it with. If they have seasonal versus if they have perennial. I am not going to you know what, forget it. I'm not going to go that. Just know that as long as they're over the age of 5, okay? I don't need you to know the difference between like if they have SAR or PAR. Just over 5, okay? And then looking at our comments, just know that we don't have enough studies right now for pregnancy. Has it been used in pregnancy? Yes. If I ask you on the exam, your answer, I'm not asking you this on the exam, so I'm not going to say it like that. Not worrying about this for pregnancy. And then this, you see if it's used for less than 4 days, and for the condition of like their nose running, then make sure that you understand that this could be something that, like, most of the time we will see this used to help those symptoms that those patients are experiencing. All I want you to know for this drug, mechanism of action, your adverse effects, and what the drug is. And then understand that you're going to see this in almost all the other conditions that we talk about, so remember the route at which you're looking at this in when we're talking about allergic rhinitis. So this is for allergic rhinitis when we're talking about our nasal spray. Mast cell stabilizers. So our mast cell stabilizers take a minute for them to work. Essentially what they're doing is they're trying to stop the mast cell from undergoing degranulation, which then leads to the histamines being released, and then that whole cascade, which would lead to inflammation in our allergic response, right? So I'm trying to stabilize the mast cell so that it doesn't undergo degranulation. When you're looking at this, you can see that most of the time when we're trying to use this, we want to use it as a preventative measure. So these are more beneficial if you know something is coming, right? Like if I know that a certain season is coming, if I know that I'm going to be in a situation that is going to, for a period of time, and then I'm going to have an allergic reaction to whatever I'm around, like I have to go stay with my friend who has a cat, right? I know that's happening, so maybe this is a situation that I can use it. The reason why I say that is because it's not as effective as a lot of our other medications, and it takes a long time for it to kick in, for it to actually work. So 1 to 2 weeks is what you need to see effectiveness. So if I am currently, or I am like, hey, I am not happy, I'm waking up in the middle of the night, this is not the drug that you're going to go to for me to get quick relief, right? It's going to take me a minute before I have relief. So 1 to 2 weeks. So again, we try to say, hey, if you know it, that I'm going to come in contact with an allergy, or you know that a season is coming, that's where we can see this medication used. Adverse effects aren't horrible, but that aftertaste, again, because of the spray, the stinging, the sneezing after they administer it, just make sure they don't blow their nose with any of our intranasals. The one med that we've been talking about here is going to be your cromolyn. You see that we have that low age, so we can use it in our patients who are at least 2 years of age. And then understanding that this is also something that is available now over the counter, but you do have the ability to write a prescription for it, and we can fill that for our patients. So again, just make sure that you're understanding this one takes a long time, bless you, for it to work. I can use it in my 2-year-olds. I can also get it over the counter, and understanding that with this, they're going to have to use this several times throughout the day. Short duration of action with this drug. All right, 34-year-old non-pregnant female comes to the clinic. She wants help with her allergies. Her symptoms are 5 days a week for the last 6 weeks, and she complains that her constant sneezing and runny nose interferes with her work performance, which is considered moderate to severe and persistent. Which medication is the best option that we can use for this patient? Very good, right? So we can give her fluticasone intranasal, because this is my steroid that I have. Not a horrible option for me to like make her flush her nose, right? She can also use this. And then if I told you that she was congested, then we could add on, right, my pseudoephedrine. And then this is like more so because she was moderate to severe and it's persistent. Remember, we prefer our inhaled at that point over our oral. So that's the distinguishing factor that you have when we're looking at those two. All right, we almost done. And then, are y'all done for the day after this? No. Okay, let's take 5 minutes real quick. I've got all kinds of options that are available. So when I look at here, I can have a cold compress if someone is just complaining of itching. I can also do artificial tears. Those artificial tears are essentially the same thing as your saline that we talked about, the saline irrigation for the nose. Your artificial tears are the same thing, except they come in pouches that are individual, like individual drops. When we talk about these are very expensive over the counter. But you can write a prescription for them, for your patient to get them from the pharmacy, and they will love you for forever, because I think they're like $30-something over the counter. Make sure that they understand that those are single vial, like little droppers, and some people will try to save them for a long period of time. The issue with that is that they don't have preservatives in them. So if something does get in there to contaminate it, they're going to drop it back into their eye and then contaminate their eye. So make sure that you understand with those artificial tears that your patient knows those are single use vials that they have. You have different decongestants that you can use. So look in here, I have a decongestant that's going to help me with my redness. I have antihistamines, the mast cell stabilizer, see how this is like repeating itself. And then my NSAIDs, if someone is complaining of like, hey, my eyes are just very, very itchy, I have some NSAIDs that we can use. And again, the route is going to come into play whenever we're talking about this. You see that again, your antihistamine decongestants or your antihistamine with your mast cell stabilizers that you can use. And then if it gets really, really bad, you refer them, and they will be put on steroids, and they will be monitored on those steroids that they're put on. Okay, so just understand if it progresses to this point, that's usually not going to be you when we're talking about the eye. The eye, we're doing these things that are up here that we're going to talk about a little bit more. Looking at your management that you have, like before, we talked about, hey, avoid the allergen if you can avoid the allergen, right? Tell your patients about cleaning up, tell your patients about dust mites, tell your patients about vacuuming, all of the things. So avoid the allergen if they can. Now, if they have symptoms, make sure that you continue up the ladder, right? You start low and then you kind of adjust with what you need. So mild, moderate, or severe symptoms will determine how you're going to treat that patient. So if they're mild, you can use some oral or ocular antihistamine. So now instead of my intranasal, right, I'm now looking at ocular. So that's why I was telling you that route is just different. So pay attention to allergic rhinitis versus allergic conjunctivitis. Artificial tears, those cold compresses that we talked about. Moderate, you can see that you have your ocular decongestant. So when we talked about our rhinitis, we were saying like, hey, my nose is congested, right? I can't breathe out of my nose. Versus whenever I'm talking about my allergic conjunctivitis, my eyes are probably very red, right? So I'm trying to release that redness whenever I'm talking about my decongestants here. You see your antihistamine plus or minus that decongestant. I have a mast cell stabilizer, and then you can see that I use that with the antihistamine. And then I have ocular NSAIDs, which are going to help with itching. And then when I say ocular NSAIDs, they're just NSAIDs in the form of an eye drop. And then severe, that was where we were going to refer them, right, because they're going to probably put on a steroid. So, looking at our non-selective antihistamines that we have now for our eye, so that is going to be our route. H1 receptor antagonist, adverse effects, again, the more that they've been rubbing on their eyes, the more likely they are to experience that stinging or that burning. And also just because our eye is very sensitive and I'm putting a drop into it, right? So you see that stinging and burning is the big thing that you're going to see, anticholinergic effects. So sometimes, especially if they use these a lot, you'll see where that dryness becomes more of a thing and they may need you to prescribe a lubricant for them. If they do have a lubricant prescribed to them, or you know that they're taking a lubricant over the counter, they should be putting in their medicated eye drop before putting in a lubricant, right? If I put in the lubricant first, it is going to lubricate my eye and my medication is not going to get in there as much as I would want it to, right? So your eye drop would go in first. They typically will tell you to wait like 5 to 10 minutes before, in some cases they'll tell you 15 minutes before you put in another drop or before they put in their, put on their lubricant. That bitter taste, again, right, all connected. So you're seeing like these adverse effects are very similar as we continue to go through these, regardless of if I'm doing it in my nose, if I'm doing it in my mouth. And then this mydriasis occurring, again, just make sure that you're watching out for your patients who have glaucoma. The medications that we have here are going to be your azestolin and your levocabastine. Most of the time what you're going to see prescribed is going to be your azestolin. And you see that this one is a very good medication, not dosed very frequently, but I don't need you to remember that dose. You see I have two different ways in which I'm using this medication, right? So I'm an antihistamine, but I'm also decreasing the amount of those inflammatory mediators and that histamine release that's going to happen from the degranulation of my mast cell. But we more so will categorize this as an antihistamine, even though it has those dual properties. We're going to talk about another medication that is selective, which is called Patanol. We'll get to that on the next slide. That's olopatadine, and it's better than using our azestolin. And the way that you can remember that, non-selective is kind of all over the place, versus your selective is going straight to the source, so it's superior. And then your levocabastine, because this is a suspension, so this is a formulation thing that is a very important counseling point for your patient. Because it is a suspension, your medication is suspended in that delivery vehicle. So you have to shake it up, versus if something is a solution, you don't worry about making them shake it. But because this is a suspension, they need to make sure that they shake it before they put that drop in the eye. Looking at your ocular antihistamine, more now selective, you see that you have your ketofen, and your olopatadine. Your olopatadine is the one that you are going to see prescribed more here. Your Zalidor or your ketotifen is over the counter. Again, don't worry about dosing, but this one is a very, very good medication that we have available for us, the olopatadine. Mechanism of action, still that H1 antagonist, but now we're saying that this is selective versus non-selective. And this is more, these two are more effective medications, with Patanol being the one that you're going to be prescribing more often than not. And then this right here, where you see this fast-acting antihistamine relieved with prophylactic actions. So let's say I know that somebody is going to encounter that allergen, right? That's what it's meaning by a prophylactic action. Or if I put someone on a mast cell stabilizer that I know is going to take a while to work, I can immediately have them on this as well, okay? And getting a relief from this medication first. Looking at our decongestants, again, mechanism very similar to what we talked about before, your alpha agonist, trying to decrease the redness that they have, again, limiting to those 3 to 5 days, because if not, they will have that rebound redness, okay, that will occur to them. So same thing like we talked about with that Pharm, right? They will have that rebound congestion in their nose. Now they will have that rebound redness that they're experiencing in their eyes. Adverse effects are very similar. The rebound hyperemia, you see that here we're saying that they say that you can do less than 10 days. Just go to the 3 to 5. Again, remember the 3 to 5. And then that mydriasis, same thing that's occurring that we talked about before. Looking at our ocular decongestants that we have available, you see your tetrahylazoline or your Visine. This is over the counter. You know, a lot of people use this. Very good acting medication, very fast acting medication. And then you have your nathazoline with your phenylaramine in it. Again, this one is over the counter, Visine allergy, just a marketing thing with a different drug added into it to kind of help with the redness that they're experiencing. So very frequent dosing, but very effective medication. Make sure that your patient is sticking to what that dosing regimen is at every 6 hours while they're awake, but not to overuse it. You'll see some people where they just like drop Visine in all the time, right, as if it's a lubricant. And this is an actual medication that can then worsen their redness that they're experiencing, that rebound. Here you have your ocular mast cell stabilizers. Again, trying to stabilize that mast cell so that it doesn't degranulate and release the histamine and all the inflammation that we will be seeing in our patients. Your clinical use, again, make sure that you're understanding that this is more so for your consistent, persistent type issues where you know what's going to be happening because they're very, very slow acting, right? So more so prophylactic issues that are happening. Looking at your adverse effects, you see that they have the stinging and the burning and the headache. Your chromalin or the Optichrome now that you see, this is the one that we already saw used when we were talking about our rhinitis. Okay, and then you also see that you have lidoxamide and metachromyl. The one that you see used the most is going to be your chromalin, but these are all 3 options for you. So remember, your mast cell stabilizers are so slow. Okay, they're very slow, and you can try to use them by themselves if you know what somebody is going to be encountered. So like prophylactically, you're putting it on. Or if you're saying, okay, cool, this is going to be how you are for this entire season, we're behind the 8 ball, I can still give you an antihistamine to work immediately, give you that quick relief, and then I can put this mast cell stabilizer on for that more long-term relief that they would need. Looking at our ocular NSAIDs, so this is the first time that we're seeing these, decreasing that prostaglandin production. Prostaglandins are going to be what cause inflammation. You'll also see those in pain and in the itching. So if I give them this and decreasing that prostaglandin production, the idea is that they won't have as much pain and itching. And a lot of these patients are going to have a lot of itching whenever they present to you. Stinging and burning, again, can occur, especially if they have used it, if they've been rubbing their eyes a lot. And then if they have sensitivity to using any NSAIDs, again, just make sure that you're being mindful that it could potentially cause issues in those patients as well. So just be mindful of those, monitor those patients. And then your ketorolac is the drug that we're talking about. Brand name is Acular. Again, don't worry about the dosing. Ketorolac. Remember ketorolac, right? We talked about NSAIDs, so now just a different route, okay? Looking at my ocular steroids that I have available, remember, if we get to this point, we're referring our patient. I want you to be aware because you could see a patient who comes in and they are on an ocular steroid. So this is just helping with inflammation, looking at this more so for your severe chronic type issues that you're having. And again, they're going to be monitored by ophthalmology probably if they had an issue with this. Adverse effects, Increased ocular pressure, so thinking about patients who have glaucoma, anybody who has cataracts, like this will be worse for them. Their vision can potentially become a lot worse. And then that increased risk of ocular infection. Why is there the increased risk of infection? Steroids, right? I'm using the steroid. So the longer that they're on them, the more likely also. Another reason why some people get infections with these is because they will touch They will touch the tip of the dropper onto their eye, and if they do have an infection, now they put it on the tip of the dropper, and they're going to continue to reinfect themselves every time they put in those drops. So again, make sure they're not touching their eye with their dropper. The medication that we have is going to be your letrozole or Alrex. Again, very frequent dosing. Looking at this, the same things that we talked about before as far as the adverse effects and the fact that you're going to refer them and that they're going to be monitored by ophthalmology while they're on this medication. That's all I want you to know from here. All these other things are just telling you more information about the drug. But again, just remember what your ocular steroid is and the mechanism in which it works. All right, for the last slide, we have the eye drop administration. So how are they putting these eye drops in? Again, make sure that they're not touching that dropper actually onto their eye. They're putting their head back. What is a little bit weird that most people don't think about, so after they create the pocket, like for the drop to go in, so they just kind of gently squeeze here. If they have contacts, make sure they don't have their contacts in. But they will squeeze and they make a little pocket, and then you put your head back to do the drop. Once you put in your amount of drops, you're supposed to tilt your head down. I had been a pharmacist for I don't know how many years before I saw this, because I don't even do this. So you're supposed to tilt your head down. Most people will try to stay like this, but you're supposed to tilt your head down. Now 2 to 3 minutes, nobody's really doing that. But essentially what we're trying to do is avoid it from draining out of their duct, okay, through the tear duct. And then remember how I already told you for them to not blink hard, not to wipe their eyes, like try to let the medication get absorbed right over that surface area as much as they can. And then sometimes too, avoid like that systemic absorption that they could potentially have, which is why we're definitely making sure that they wash their hands and not causing an infection. You press on that tear duct, and that tries to avoid a bunch of like systemic adverse effects from the drug. So it keeps it in that eye, in the ocular area instead. Again, depending on which drops you're using, you will see where they need to wait at least 5 minutes. I told you sometimes I've seen upwards of 15 of where they would have to put, in which they're waiting before they insert that next drop. Okay, so again, these are our main things that we have when we're talking about our drops. We'll be here tomorrow either way, with a test or not. I will text your class leader to let him know what happened.